Assalamu alaikum. This is a lecture about anticoagulation during ECMO. And in this lecture, we will cover the basics of anticoagulation, how to monitor anticoagulation, and the concept of manufacturing and developing the extracorporeal system. We will not go for different protocols, as it's a matter of debate, and it depends on center preference and experience. Patient on ECMO will have thrombosis or bleeding. Both of them can happen, and we should, while managing the patient, has fine-tuning in managing ECMO patient. Regarding anticoagulation, we can't set this is fixed dose for each patient. Why? We have two types, VA and VV. Both of them are different. We have different response of patient. Some patients need a higher target because they have a thrombotic event. Some of them need a lower target as they may have bleeding. The response of each patient different from one to one. So each anticoagulation treatment should be tailored based on each patient. Why do we need anticoagulation in ECMO? The answer is no endothelium. There is no endothelium, there is artificial surface, so that will stimulate formation of the thrombus. As I mentioned before, the presence of artificial surface will stimulate coagulation and inflammatory system activated when the blood come in contact with ECMO circuits. Traditional coagulation cascade has been replaced with the cell-mediated based model of coagulation. In this model, there are three phases of clotting initiation. The exposure to foreign surface resulted in protein absorption, and that lead to platelet activation and adhesion, which is the propagation. And the third phase is fibrin and thrombus formation, which is the amplification. And in this graph, we can see started by injury, then the clots start to form till we have third thrombus formation. When the blood comes in contact with the foreign surface, there is a release of systemic inflammatory mediators, then activation of complement, kinin, and coagulant, and there is an increase in release of systemic inflammatory response and formation of the thrombus. That's why the cell-based models are providing a clear picture about the enzymatic cascade, how to work, and allowing the clear picture of crosstalk between the inflammatory and coagulation system, which should be appreciated by the clinician for true understanding of the hemostatic picture in ECMO patient. There's a study, multiple studies. One of them found that patient after 5 days from starting ECMO, there will be decreasing in platelet counts, there's consumption of factor 12, and decrease in fibrinogen and increase in fibrin degenerated product. So there will be consumption of coagulation factors, hemolysis, and increased fibrin degenerated product. What are the criteria of anticoagulation use? Easily titrate with a clinical effect. It has short half-life, prevent clot formation, availability of antidote, and easily monitor. What is the anticoagulation used? Unfractionated heparin, which is the standard treatment for anticoagulation. We can start with bolus 1000 international unit, and infusion can be ranged from 800 to 1000 international unit per hour, and targeting ECT from 180 to 2020 seconds. What is the anticoagulation used? Argatropan, which is feasible and safe effective. There is not much experience about it, as most of the work is about case reports. The argatropan can be used in patient who has had heparin-induced thrombocytopenia, so it can replace it. So the loading dose can be started, followed by 0.1 to 0.24 microkg per minute as a continuous infusion. Same as Icatropan is bivalirudin, which is preferred in liver patient, and the bolus dose 0.15 to 0.5 milligram per kg, followed by 0.12 to 0.25 milligram per kg per hour, and still there is no much work about it, and need more clinical trials to prove its efficacy. There is two different category between the heparin and direct thrombin inhibitor, which category contain igatropine and bivalirudin. Heparin is short-acting. It's the most experienced drug. Have antidote protamine, affected by hepatic impairment. It's not expensive, but the main complication is heparin-induced thrombocytopenia. Direct thrombin inhibitors, they are short-acting. There's less experience in their using. They are expensive, no hits, and not affected by antithrombin level. Bivalirudin have enzymatic and renal excretion. Argatropan have hepatic metabolism. Monitoring of anticoagulation. It's very important to know which is better, or the question you will ask, which better, ACT, active clotting time, or activated PTT, partial thromboplastin time. The one who you are used to and the one you have it in your protocol for using anticoagulation is the one you should use on ECMO patient. So for activated clotting time, it's a bedside test. It's easily done, and it's like exposure of the whole blood to clot on exposuring it to activating factor. Activated PTT, which is a plasma-based test, so there is no platelet effect. It can be performed on saturated blood, so the effect of calcium is not present. And the third test is thromboelastogram, or TIC, and it is measuring to somehow measuring thrombotic effect, the need for fresh frozen plasma, the need for platelet, and fibrinolytic effects. We should give tranexamic acid. And anti-activated factor 10. So this is the effective heparin concentration in the plasma, and it's very sensitive to relation between the heparin and antithrombin activity. Other monitoring labs needed during ECMO, like platelet count, antithrombin, D-dimer, fibrinogen, and free hemoglobin level. The target anticoagulation test in uncomplicated case for ABTT 1.5-fold, and for active ACT, active clotting time, 180 to 220 seconds, and for anti-factor 10, activated factor 10, so we should target the anti-factor 10 level of 0.3 to 0.8, whatever the test you are used to. In some cases, we can go lower level if we suspect there is bleeding. In some cases, like presence of pulmonary embolism, the patient has a coagulation disorder and certain disease, we can go to a higher level if depending on the clinical situation of the patient. As I said in the introduction, that there is difference between VV and VA ECMO. For VV ECMO, BTT can be accepted 40 to 50, and VA ECMO can be accepted from 50 to 60. Sometimes when I ask some of my junior colleagues about which need more can anticoagulation, the answer is VV. And VV is venous to venous and slow circulation, and this is wrong answer. The one who need to be anticoagulated is VA ECMO. It's need higher anticoagulation. Why? Because the return cannula will be in exposure to aorta, and that can lead to atheromatous plaque, formation of the thrombus. So the one who is needed higher anticoagulation is VA ECMO. Another important question is, can we run ECMO without anticoagulation? Yes. The answer, yes, we can run ECMO without anticoagulation, especially with the modern circuit we have. Sometimes we can run for 5 hours without anticoagulation in VV ECMO. But what about postcardiotomy ECMO, VA ECMO, and the patient has high rates? Can we run? Yes, we can run up to 48 hours without anticoagulation. But in some condition, we should know that the patient should have full flow. We should have careful monitoring for the patient and for the circuit and for the lower limb ischemia. As patient to postcardiotomy sometimes have a change or affection for the coagulation factor, and the effect of bypass machine is typically or to some extent equal to the effect of ECMO on the coagulation cascade. So we can run up to 48 hours. Is antiplatelet needed routinely in patients on ECMO? No, it's not a standard of treatment. And the patient, as long as he is on VVA ECMO, we will not use antiplatelet unless it's indicated. But sometimes in patient VVA ECMO who has recent MI or recent stent, sometimes antiplatelet may be needed in addition to anticoagulation with heparin. As we mentioned before, the starting of thrombus formation depending on adsorption of plasma protein to the ECMO circuit. So there's developing of concept of pre-coating or surface modification by manufacturer. So some of the circuits are heparin coated. Some of them are started to use phosphorylcholine. So they try to decrease protein absorption on the protein absorption to the circuit, so that decrease the rate of thrombus formation and the need for high PTC and presence of anticoagulation. This is reference of this lecture besides Elsoret book. Thanks for listening to this lecture and waiting for your comment.